Thanks, Dave. We'll have our next speaker come up here. Rick Wiggins is going to be talking to us about evaluating facial weakness. And he's coming up here. Any questions while Rick is coming up for the previous speaker? Hopefully Rick's not going to show any stringy pizza.
For my first trick. Okay, I've got 3 minutes left. Thank you very much. It's really an honor to be here and to be included by Liddell with all these great speakers at the conference this year. I hope you're appreciating it. So I'm going to talk about facial weakness. So as you've heard with all these cranial nerves, we're thinking about imaging kind of from the origin nucleus out through the end organ. So if we have a patient with a whole bunch of problems, we're not thinking about the isolated cranial nerve. But in the patient who has an isolated cranial nerve deficit, we want to think about imaging from the origin nucleus all the way out through the end organ every time. So for the middle ones, 5 through 8, we usually think about the pons. For the first ones, 1 through 4, and the mesencephalon above. And for the lower ones, 9 through 12, you hear in the next lecture, below the pons itself. So I'm going to be talking about the 7th nerve itself. And I have nothing significant that I'm ready yet to disclose with you. So we're going to look at the anatomy. So we're going to look at the anatomy of the 7th nerve, and we'll do everything from centrally going out to the periphery. And then we'll look at some of the pathology and the imaging, and we'll look at the important imaging characteristics and how we can differentiate these pathologies that happen along the facial nerve itself. So we're going to start off again looking at the anatomy, and I'm going to go from the inside out, starting from centrally on each one. So the facial nerve, along with the 5th trigeminal nerve, is one of the more complicated. We have different functions, and it has a very tortuous course through the temporal bone itself. And we have all these different segments that we can talk about. And if we pay attention to the subtle anatomy, we can see that sometimes the same pathology can have very different appearances based on which part of that anatomy the pathology actually shows up along. So it's a mixed nerve. We have 3 different functions. So it makes sense with 3 different functions that we have 3 central cranial nuclei that contribute to one 7th cranial nerve. So mostly branchial motor. So all your voluntary and involuntary facial expression musculature is from this nerve. We also have some visceral motor, mostly parasympathetic fibers, lacrimation of the lacrimal gland, and we have special sensory taste through chorda tympani, anterior 2/3 of the tongue. So here's a graphic through the cross-section of the pons. And when we think about where the 4th ventricle is and the facial colliculi, the little bumps that are anterior to that, the motor nucleus below that is 6. And those fibers of 6 come out anteriorly off the pontomedullary junction. The motor nucleus of 7 is immediately anterior and lateral to that. And those fibers do kind of a strange thing. They actually start in the wrong direction. They wrap around 6, and then they come out the ventrolateral pontomedullary junction laterally. And they pass in between the superior salivatory nucleus and the solitary nucleus. So this is an axial section, obviously, but a lot of these nuclei extend up and down through the pons and the pontomedullary junction. They may contribute to different cranial nerves, but when we think about the 7th nerve, we look at those facial colliculi, the little bumps that are in front of the 4th ventricle, and if we have pathology at that location, we can get 7th nerve problems. So they all come out in that area. We think about where the little stria medullaris is at the 4th ventricle in this picture in the back. If we cut out the posterior fossa, we can see where they arise. So here's the pons, here's the medulla. So this is pontomedullary junction. 6 comes out just off midline, and 7 and 8 come out ventrolateral pontomedullary junction. Now you see in this graphic, like a lot of the pictures, it looks like there's 3 little nerves here. Frequently in older anatomy books, they would draw the big vestibular cochlear nerve and the 7th nerve with the little nerve in between, nervus intermedius, it's often referred to as. That's actually those other fibers. So they draw the motor fibers of 7 as one nerve and the special sensory and the parasympathetic fibers as a little nerve in between, nervus intermedius. In reality, it's wrapped in one perineurium. So we see 2 nerves coming out there. But if you ever see this in anatomy books, that's what they're trying to differentiate, how there are different functions of this. That little nerve in between is the nervus intermedius. So in the internal auditory canal itself, we have the 7th nerve superiorly, and we think about those different segments as it goes through the temporal bone itself and its relationship to the cochlear and the superior and the inferior vestibular nerve. So here's a picture where we've kind of separated out the functions of the 7th nerve itself. So we have a little labyrinthine segment going to the anterior genu or geniculate ganglion. That's where those parasympathetic fibers that are the greater superficial petrosal nerve come off. Those are going to join the sympathetic fibers that travel the carotid to become the pterygoid or Vidian nerve through the pterygoid or Vidian canal. The rest of the fibers go through the temporal bone, so that's the tympanic segment, and then we have a descending or mastoid segment that goes down inferiorly. There are two branches off that descending mastoid segment. One is little stapedius, and one is at chorda tympani, which strangely does this loop through the middle ear cavity. Comes out this little fissure anteriorly, and then it joins that anterior division of V3 to go forward and become the lingual nerve towards the tongue. The rest of those motor fibers are coming down through this hole at the stylomastoid foramen, and it goes forward, pierces the fascia on the back of the parotid, and then splits in the pes anserinus. So we can think about all these different little segments as different parts of the facial nerve itself. So there's a part going through the CP angle cistern, so that's a cisternal segment. There's a part going through the IAC, so that's a canalicular segment. There's a short segment, 4 or 5 millimeters, going by the labyrinthine part of the ear. So that's our labyrinthine segment. That goes to the anterior genu. That's where we have the greater superficial petrosal nerve come off. Then we have a part going back through the temporal bone, so that's our tympanic segment, and it goes just under the lateral semicircular canal. So here's that tympanic segment going back posteriorly, and the greater superficial petrosal coming anteriorly, and that goes just lateral to the horizontal segment of the carotid here. And the coronal plane, here's our labyrinthine segment coming towards us, and the tympanic segment going back just under the beak of the duck, the lateral semicircular canal. And then we have our posterior genu, and then we're going to have our descending or mastoid segment going down inferiorly. So when we look at the back wall of the middle ear cavity, if we scroll up and down near the level of the EAC, it looks like there's one tube that's opacified. That's going to be our facial nerve descending or mastoid segment for us going down. So here posterior to the EAC is that descending mastoid segment going inferiorly. Now we have two little branches coming off. Again, when we think about that middle ear cavity, we've got 3 ossicles in there, we've got 4 suspensory ligaments, and we've got 2 little muscles that are going to there. We have the tensor tympani coming from V3 anteriorly, and we have this little stapedius muscle helping the stapes hold that in place. And then again, there's a sharp turn where we have the chorda tympani come off that descending mastoid segment, and it does this strange thing, actually looping in between the long process of manubrium of the malleus and the long process of the incus to go out anteriorly. So that's our chorda tympani. So we have 2 branches coming off the descending or mastoid segment of the facial nerve. And here's just another picture of that. Here's our chorda tympani looping through if we have a perforated eardrum in between the malleus and the incus. And here's that little stapes muscle going over the stapes. So both those 2 little muscles are helping clamp down those ossicles with loud noises so we don't just perforate our eardrum or the oval window. So at the stylomastoid foramen, again, just like all those other cranial nerves, we look for a good fat pad at that location. We want to see nice fat below every foramen of the skull base. It pierces the back fascia of the parotid, and then it splits in that pes anserinus. All those branches, temporal, zygomatic, mandibular, buccal, cervical, except all of those branches that extend out over the face. So here's those branches again. Greater superficial petrosal is coming off the anterior genu. We have 2 branches from the descending or mastoid segment, stapes and the chorda tympani, and then all the branches of the pes anserinus, goose's foot, as it spreads out through the parotid itself over the face. So on imaging, we see here again there's 2 nerves coming out. So the big vestibulocochlear nerve and the smaller facial nerve, both going over to the IC. So on our CSF bright sequences, whether you're doing a KISS, a T2FSE, a SPACE, a Fiesta, whatever sequence you have with your vendor, we have the nerves very nicely shadowed here. And if we have vascular loops, we look for those flow voids around it. We know that the surgeons look for a ICA right where 7 and 8 are coming out the pontomedullary junction. So just because we see a flow void at that location is not the same as a vascular loop syndrome or vascular compression of the facial nerve as it's coming out. If we do the oblique cross sections, we see the big vestibulocochlear nerve and we see the facial nerve. We sometimes see additional flow voids if there's an AICA loop that's extending into the IC. As we get into the opening of the IC, the porus acousticus, we see the big vestibulocochlear nerve in back. Here's the facial nerve on top. This is the cerebellum, so I know that's posteriorly. As we get to the midpoint, that's where we remember 7 up and face and coke down. So the facial nerve is on top superiorly, cochlear nerve is inferiorly on bottom. And then we have the facial nerve labyrinthine segment going forward. immediately superior to the cochlea, and superior and anterior to the vestibule as we go out laterally. Look, it's a boy. So then on CT, we're going to see the intraosseous segments as we go through. So we have the little tiny labyrinthine segment going forward through the labyrinthine part of the ear. So it's just 4 or 5 millimeters going anteriorly. Then we have our anterior genu and the tympanic segment. So that's about 1.5 centimeters. That tympanic segment going back just under the lateral semicircular canal. Then we have our posterior genu, the posterior turn. And then we have our descending or mastoid segment where it looks like one mastoid air cell is opacified, extending down inferiorly, posterior to the external auditory canal. So same thing on the coronal view. If we look laterally within the IIC, we see this little horizontal crest or Bill's bar as we see the facial nerve labyrinthine segment coming anteriorly. So we can follow that labyrinthine segment right there over the cochlea itself to the anterior genu. So this is our anterior genu. And then we can follow the tympanic segment going back. We want that tympanic segment to go immediately posterior and inferior to the lateral semicircular canal. So here we get into the duck's head. So the head of the duck is a vestibule, beak is a lateral semicircular canal, neck is going down to the basal turn of the cochlea, and we see the tympanic segment immediately under the lateral semicircular canal. So here's that tympanic going back to the posterior genu. We can follow it all the way back. And then we see the descending or mastoid segment going down to the stylomastoid foramen. So if we do take the time to do obliques, we can sometimes get pictures where we see that tympanic posterior genu and the descending or mastoid segment drawn out very nicely on that obliquity. If we look very closely, we can see other structures around it. Sometimes if we look at the posterior descending mastoid segment, we see the soft tissue and the pyramidal eminence where that little stapedius muscle is coming over. We see here nicely the anterior and posterior crura of the stapes. So we have a little branch coming off the descending or mastoid segment going anteriorly. And again, when we think about all those little fibers and the different functions of the facial nerve branches, we can sometimes see little branches as we come off. So here's that chorda tympani making that sharp turn, strangely, off the descending mastoid segment as those fibers come down and the special sensory fibers turn around and come up to go through the middle ear cavity. If we look very closely at the axials, again, we sometimes see a little branch coming off, and we can sometimes follow little nerves in that area. So if you hear people talking about those little branches or branches of 9 and 10, Jacobs and Arnold's nerve, you might see those little branches as they come near those areas. So on imaging, we see these very well, and we know that there's some enhancement that normally happens around it. So we're frequently trying to figure out, is there too much enhancement along the 7th nerve itself? So here's that horizontal segment of the carotid, and we see those little fibers of the greater superficial petrosal. They're nicely enhancing here in this pathologic case. There's always a break here at the horizontal segment of the carotid. That's where those sympathetic fibers from the carotid join the parasympathetic fibers from 7, and together they form that pterygoid or Vidian canal going anteriorly. So if you ever want to explain the facial nerve, this is a paper clip. So you can unfold the paper clip to do that shape. So this is your left facial nerve segment. I cleaned my fingernails before I made this video, the second time. So if we unfold the paper clip like this, we see those segments. So cisternal, a labyrinthine segment coming anteriorly to the anterior genu, the tympanic segment going back, and then we have our posterior genu and the descending or mastoid segment. So that's your left facial nerve in paperclip form. So that's the anatomy we're looking at. Again, with all these cranial nerves, we want to think about imaging from the origin nucleus all the way out through the end organ. For most of them, if we just start behind the pontomedullary junction and go out through the face, you usually cover the area of interest, except for the recurrent laryngeal going down. So we can go look up the anatomy later, or if the referring docs get confused between facial pain and facial weakness, is this really 5 or is it really 7? We can image from behind the pontomedullary junction through the face, and we can go look up the anatomy later to be sure we're looking at the right place for pathology. The important thing is to think about any pathology in an isolated cranial nerve deficit problem. So again, just like that anatomy, we're going to start with pathology centrally and go out distally along the facial nerve course. So here's the pons, here's the medulla. So there's pontomedullary junction. So here's 6 coming out off midline, and we see 7 and 8 here ventrolaterally going over to the IAC. So we think about any pathology that can happen along that course. Now, we do have kind of a pseudo-lesion of normal anatomy. We used to think that any enhancement along the facial nerve was abnormal, especially when we're just on 1.5T. As soon as I put in our 3T, I was seeing facial nerve enhancement on every case. So we're living in a time that our technology and computers are advancing so quickly, we have to be able to learn, unlearn, and relearn material as we're seeing this anatomy better and better all this time. We do normally see some enhancement at the geniculate ganglion, at the tympanic segment, less commonly labyrinthine, and then less commonly at mastoid segment. But it is normal to see a little bit of enhancement now, especially if you're doing 3T scans, along the facial nerve course itself. So we do see a little bit of enhancement normally, labyrinthine, geniculate ganglion, and tympanic segment. But again, any pathology anywhere along that course. So here's a nice case of a cavernous malformation. On the gradient, we see old blood pushed to the periphery. A lot of blooming on the gradient here, on the T2, sorry, old blood pushed to the periphery. On the T1, maybe a little bit of T1 shortening, good for blood, and a little bit of enhancement. But we can see where this is right in relationship to the facial colliculus, and we know right where the motor nucleus of 7 is under that. So you understand why this patient could show up with 7th nerve problems. If we have multiple sclerosis, if we have an MS plaque near that location where we think about those fibers of 7 coming out the ventrolateral pontomedullary junction, or if we have trauma, if we have fractures, we think about longitudinal and transverse oriented fractures, but we know that the transverse theoretically is about a 50% chance of hurting the facial nerve because it has this tortuous course. And we see here that short 4 or 5 millimeter section of the labyrinthine segment of the facial nerve. We have a fracture right through that itself. So then pathology along the nerve itself. So we have some pathology that can happen anywhere along its course. And it's interesting because of the very different osseous anatomy around the facial nerve course, the same pathology can have very different imaging appearances depending on which segment it shows up along that course itself. So first we have a herpetic or a Bell's palsy, idiopathic acute onset lower motor neuron facial paralysis. On CT, all the osseous structures are normal, but on MR we see diffuse enhancement all the way along its course intratemporally, and we see a tuft of enhancement laterally within the internal auditory canal. So here's a case where we see nicely the labyrinthine, the geniculate ganglion, the tympanic segment, the greater superficial petrosal extending out. The posterior genu and the descending mastoid segment are all avidly enhancing on this post-contrasted MR. And here's kind of a tuft of enhancement laterally within the IAC. Not a focal ball like a vestibular schwannoma in the IAC, just this vague tuft of enhancement. We normally don't image these patients with a herpetic or a Bell's palsy. If somebody's used to seeing these patients, is trained in otolaryngology ENT surgery, they're usually comfortable following these patients. It's the ones that don't get better or have an unusual presentation that we may image usually. Next, we have a schwannoma. So we can get nerve sheath tumors anywhere in the body. We usually talk about them on the larger named cranial nerves. But this particular tumor, when it happens along the facial nerve, has a very different appearance based on which segment it actually occurs along for the facial nerve itself. So clinically, the clinical presentation is depend on its location. On imaging, we see a tubular mass and it avidly enhances. The clinical different presentation is actually very interesting. Some of these cranial nerves are more sensitive to external compression than other nerves are to internal derangement. It turns out if you have a facial nerve happening in the cisternal or canalicular segment, it pushes a cochlear nerve up against the wall, and the patient may show up with hearing loss. Well, if a guy's got hearing loss and you see a mass in the IC, we're probably thinking vestibular schwannoma in that case. So we want to be very careful about those lesions. If you have an IC facial nerve schwannoma, it may look a lot like a vestibular schwannoma. So we want to look to be sure there isn't any enhancement along that little labyrinthine segment going anteriorly from the nerve. So here's an axial CSF bright sequence, T2FSE, KISS, SPACE, Fiesta, whatever type of sequence you're doing. And this patient had a pretty nice ice cream cone looking lesion. It's in the IAC and extending out to the CP angle cistern. They thought it was a vestibular schwannoma, so they went and cut this out. And postoperatively, the guy's face wasn't moving. And what they didn't notice preoperatively was that labyrinthine segment was very widened, widening and enlargement of the geniculate ganglion, and we have avid enhancement along that course. So this is that tail that we want to look for along the labyrinthine segment to help us differentiate a facial nerve schwannoma from a vestibular schwannoma. A very rare pathology, but very important, obviously, to make this distinction preoperatively. This is a big critical area where we can help our ENT colleague surgeons. So next is the labyrinthine segment. So here we have very dense bone. So this is more of a classic appearance for a schwannoma, where we have enlargement of the canal at that area. And we might think about some other pathologies like a congenital cholesteatoma or perineural tumor spread. So here's a graphic showing a lesion that's not only in the cisternal and canalicular segments, but it's also extending along the labyrinthine segment to the anterior genu. And here's a case. Here's the axial CT and the correlating post-contrasted MR. We see avid enhancement in the IC along the labyrinthine segment and at the genicular ganglion, consistent with a facial nerve schwannoma, avidly enhancing and enlarging and scalloping the bones around it. Next is the geniculate fossa. So at the anterior genu, we have the brain immediately superior to it. So at this location, if we have a geniculate fossa facial nerve schwannoma, we have enlargement of the bones. Here we see on pre-contrasted T1, it's iso to brain. It looks similar in soft tissue intensity. Here's a larger lesion. This case was thought to be a meningioma. Looks like an extraaxial mass. It's benignly according and displacing the brain. Looks like it has a good CSF vascular cleft between the lesion and the brain itself. But what they didn't notice was this is actually arising from the geniculate ganglion down here inferiorly. And you can see the swirling Antoni A and B fibers within the lesion. So next we have the tympanic segment. So here we have a very thin-walled segment just under the lateral semicircular canal. So as you can imagine, a lesion at this location, as it enlarges, it may pedunculate and extend down into the middle ear itself. So here's an axial CT. We're at the level of the ice cream cone. Ice cream scoop is the head of the malleus. Cone is a short process of the incus. And we see this soft tissue mass here, but the mass is just pushing the ice cream cone out of the way. It's not destroying it itself. So we want to compare that with a cholesteatoma. Here we have a lesion that's actually destroying the cone itself and a little bit of the ice cream. So cholesteatomas, like ice cream, facial nerve schwannomas, not so much. So next we have the descending or mastoid segment. So here, around that segment, we have all these air cells. So as you can imagine, as that schwannoma enlarges, it kind of pedunculates out and fills those mastoid air cells. So it has a lumpy, bumpy outside appearance. Some people like the word bossulated, where it's lumpy, bumpy on the outside. So just like everything else, location is the most important thing here. So here's an axial CT and the correlating post-contrasted MR on bottom, and we see a large lesion here with kind of a lumpy, bumpy outside appearance as it pedunculates into these air cells and extending anteriorly towards the external auditory canal, avid enhancement following contrast. And we can nicely correlate that with the normal descending mastoid segment on the other side. And here's the CT, coronal. We see those lumpy, bumpy, bossulated appearances that extends into those air cells, and avid enhancement on the correlating post-contrasted MR. So next is a vascular malformation or a venous malformation that may happen along the facial nerve. It was classically described as hemangioma. Hemangioma is kind of one of those grab bag terms we use to describe all kinds of different things in the body. But some of these are actually lesions that are vasoformative with osteoblastic activity, and this is one of those. So clinically, they may show up with chronic progressive facial nerve paralysis. We see an avidly enhancing lesion and this weird kind of bony flex and spiculated appearance on the CT, so it can look very invasive appearing on the MR. And just like the rest of the skull base, as you see from these cases, this is an area where we're okay doing both the CT without contrast bone algorithm and the post-contrasted MR. We know that for skull-based pathologies, if we have a well-done CT and a contrasted MR, we can sometimes tell you exactly what the pathology is, and that's a very valuable thing for us. So here's a graphic where we have a lesion at that anterior genu, a popular location for these lesions. And here's a correlating case. So the axial CT on top and the post-contrasted MR on bottom. And we see this unusual enlargement of the genicular ganglion with the spiculated expansile changes and these bony flecks from this lesion. Avid enhancement on the post-contrasted views. And we see a little bit at the labyrinthine segment. So we kind of think about these lesions sometimes showing up where vascular loops and segments come together. So we might see this lesion at the genicular ganglion, or we might see it at the pores acousticus, the opening of the IC. And then we have perineural tumor spread. We know that the parotid gland may get minor salivary gland carcinomas like adenoid cystic, which really likes perineural tumor spread as a pathology. The important thing we want to think about here is sometimes they are what we call radiologic skip lesions. Because of the vasculature of these cranial nerves, sometimes there's some enhancement along the nerve and then an area that's not enhancing and then more enhancement later. But when they do surgery, it's tumor, tumor, tumor all the way along the course of the nerve. So we want to image, again, all the way along the anatomic course of the nerve when we're thinking about perineural tumor spread, and it can go proximally and it can go distally. So here's a graphic where we have a lesion within the parotid, and we see extension along that descending mastoid segment up towards the posterior genu. And here's a nice correlating case. Coronal T1 pre-contrasted and post-contrasted. We have a pathology within the parotid, extending right up through the stylomastoid foramen on that descending mastoid segment, a good appearance for perineural tumor spread from the parotid. So that may extend out distally over the face, or it may go proximally up the stylomastoid foramen, or as we heard earlier, it may go along that auriculotemporal nerve, this strange branch kind of behind the mandible over towards V3. Here's another case where he had a similar lesion within the parotid going up the descending mastoid segment, and this one was going all along the tympanic labyrinthine segment and enhancing within the lateral IAC itself. We can have metastatic disease that may happen around the CP angle, so dural as well as peel disease. So we might see dural disease that extends over towards IAC, or peel disease that extends along those cranial nerves themselves. So this is more of a dural appearance where we have enhancement along the IAC itself, but we can also get peel metastatic disease where we may have enlargement or metastatic disease being laid down on 7 and 8. So here we have thickening of the 7th nerve itself and abnormal enhancement, also enhancement within the cochlea. So we expect this to also be extending along the 8th nerve. And then lastly, to finish up, we have the herpes zoster oticus, Ramsey Hunt, if you prefer to name stuff after dead people, where we have enhancement along the course of the nerve, but with a herpetic or a Bell's palsy, we have a tuft of enhancement laterally within the IAC. In this case, we actually have more linear enhancement that we might see along the nerve itself. So here's an axial post-contrasted MR, and we see avid enhancement along the tympanic segments and kind of a tuft or more linear enhancement within the lateral IC, and we think about the vesicular rash on the ear that we may see associated with herpes zoster oticus in that area. So that's a review kind of the anatomy and the pathologies, the common things that we see along the facial nerve itself. This nerve is very complicated. We've got 3 central cranial nuclei, so we have 3 major functions of the nerve, and it has a tortuous course to the temporal bone, and if pathology happens along different segments, because of the subtle architectural changes in the osseous bone, the same tumors may have different appearances based on where they show up. And I thank you very much for your attention.